Welcome, Dr. Pawan.
सर सॉरी, कहीं अटक गया था मैं।
So,
सर
so
आप
can I
एक
share, can I
रिक्वेस्ट
share my slides,
मैं कर
please?
देता हूँ आपको hello। यस सर। सर आप कर कर सकते हैं शेयर।
I'm doing that. I hope my slides are visible now.
या दे आर विजिबल।
Okay. Thank you, Dr. Pawan, for letting me join in. It's a great honor for me, as I've already talked about. So I'll be speaking on the obstructive airway disease, which include asthma and COPD primarily. Both are actually, in general practice, not very well treated. The diagnosis is, maybe difficult, uh, especially, when you want to differentiate between asthma and COPD. So as I just said that, these are two different entities of obstructive airway disease, which have different pathogenesis, different etiology, different symptomatology, and different way of management, and they have got a different course and prognosis. So definitely we need to, manage them differently. So I'll be giving an overview of this topic. So just to set the ball rolling, bronchial asthma and COPD are obstructive pulmonary diseases that affect millions of people all over the world. And unfortunately, our country, India, has the largest number of cases of bronchial asthma and COPD, and India is the world capital of asthma and COPD. We've got the most difficult cases to treat. We have got a large people of asthma and COPD who remain undiagnosed, and many of them do not have access to the correct treatment facilities, as a matter of fact. So it becomes very important that we as a physician update ourselves and try to treat these patients appropriately so that they get the maximum benefit, because at the end of the day these diseases prove to be quite debilitating, lethal, and could have a high morbidity and mortality as well. So these two illnesses have many similarities, primarily because their symptoms are almost similar. Both of them would present as, cough, breathing difficulty, dyspnea, wheezing. These would be common symptoms, but they have many differences which may sometimes confuse therapists in diagnostics and management of these diseases. So they have a different etiology. They have symptoms which are same, but their pattern is different. Uh, they have different types of inflammation in terms of different inflammatory cells, different mediators, and different consequences of inflammation. And they vary in their response to the therapy, and they got a different course, which I'm going to talk about, in a little bit of detail. So let's define, understand what asthma is and what COPD is. And as I said, asthma is not COPD and COPD is not asthma. So what is asthma? Asthma is a chronic inflammatory disorder of the airways associated with airway hyperresponsiveness. This is the key. This word airway hyperresponsiveness is the key, is the key factor in asthma, which means that our airways becomes more reactive to our surroundings. And they react in a way that, which produce an inflammation in the airways. And then it leads to the various symptoms and consequences of asthma. Asthma is characterized by recurrent episodes. This word recurrent is important. So it's a recurrent episodes of wheezing, breathlessness, chest tightness, and coughing. So it's sort of an episodic disease, right? It is a spasmodic disease. The symptoms would come and symptoms would go. This is how it is. They are not persistent majority of time. And asthma usually has a variable airflow obstruction that is often reversible either spontaneously or with the treatment. This is again very important. So you have patient coming with low FEV1, and then next visit he comes, you find his FEV becomes normal. So this kind of variability is seen, and you have you're quite aware about the peak expiratory flow rate monitoring, where there is a variability which is seen day to day. So this has got a variable respiratory functions in terms of airflow obstruction. Whereas COPD is a disease characterized by persistent respiratory symptoms. They are not recurrent, they are persistent respiratory symptoms, for example, dyspnea, cough, and respiratory production. The airflow limitation in COPD stems from airway or alveolar destruction. So COPD actually is a destructive lung disease. It causes destruction of the lung parenchyma. And because of this destruction of the lung parenchyma, the airways lose their elastance and they tend to become collapse. So it's a destructive airway disease. It is typically caused by substantial exposure to noxious particles or gases. For example, tobacco smoke, which is the commonest cause, biomass fuel, the air pollution, and workplace hazards, environmental exposures. So this is how COPD is different. It is persistent, has got an airway limitation coming from destruction of the lung, and has got tobacco is the key factor in its etiology. And unlike asthma, which is often diagnosed earlier in life, COPD is a progressive condition. Important thing is, I talked that asthma has a recurrent episode, but COPD is a progressive condition of decline in lung function that typically appears and is diagnosed after the age of 40 years. So COPD would invariably occur after 40 years of age, and for in our common practice, as a matter of fact. Whereas asthma can be early onset. Now coming to pathogenesis. Now both asthma and COPD are associated with inflammation of the respiratory tract, but with a different pattern, which I'll explain. So factors which influence the asthma include the host factors and the environmental factors. The host factors include atopy. So these patients may have atopy of different systems. They may have associated urticaria, they may have rhinitis, sinusitis. Again, they would have airway hyperresponsiveness, which I have already explained, which is a trigger for inflammation. And then obesity is an important host factor. In fact, it's one of the phenotypes of asthma. So somebody, an obese lady who has got asthma may have uncontrolled asthma until her obesity is, managed accordingly. Otherwise, these patients would have, their symptoms and their asthma would remain out of control. Now, there are certain environmental factors which are the triggers. So there are various triggers which are responsible for occurrence of the asthma. These may be allergens, infections, occupational like environmental exposures, dusty environment, tobacco smoke, outdoor, indoor air pollution. And the various allergens could be indoor and outdoor. Indoor allergens could be dogs, cats, mice, the pet animals, cockroach, fungi, molds, yeast, and outdoor, of course, are the pollens. Whereas the risk factor for COPD is the cigarette smoking is the most commonly encountered risk factor for COPD. And air pollution resulting from the burning of wood and other biomass fuels has also been identified as a COPD risk factor. So in our country, smoking is quite prevalent, especially it's becoming more prevalent in teenagers, and now more we are seeing a significant rise of smoking in the ladies, as a matter of fact, the women, as a matter of fact. So many women are coming back with the onset of COPD. And air pollution is a big problem for us, and especially in villages where the biomass fuel is still used significantly, like chulha burning is very, very common. And these mothers, would develop, COPD later in their life. Now, coming to the inflammatory cells in asthma, you've got the mast cells, which are activated by allergens like Ig receptors. They release bronchoconstrictor mediators like histamine, cysteine, the leukotrienes, prostaglandins, etc., which cause bronchospasm and bronchoconstriction. Then the eosinophils, which release the basic proteins that may damage the epithelial cells and have a role in airway remodeling. In fact, eosinophilic asthma is a different phenotype, and these patients respond well to the inhaled corticosteroid, and many times they require high dose of inhaled corticosteroids to respond, and they are supposed to be better responders to inhaled corticosteroids. Then T lymphocytes may also play, which release various cytokines, and that orchestrate the eosinophilic inflammation, and also Ig-mediated inflammation by lymphocytes. So Ig-mediated inflammation is basically an atopic asthma, and the eosinophilic-mediated inflammation is called as the eosinophilic asthma. And they're all two different phenotypes which are important when it comes to the management of severe asthma. Whereas the inflammatory sense of COPD is different. It is basically neutrophil-mediated, which causes, mucus hypersecretion by release of the proteases. Then macrophages also play a role in COPD patients by increased inflammatory mediators which they produce and may show defective phagocytosis. Then T lymphocytes are also elevated, and important thing, there is rise of CD8 cell counts, which may be cytotoxic to the alveolar cells. So CD8 and CD4 ratio is altered as this is higher. And also B lymphocytes also play a role, especially in peripheral airways. And they are triggered due to the colonization of the infection. As I said, many times these patients have COPD patients are colonized colonization of the various microbes, which in itself leads to further triggering or persistence of the COPD in these patients. Then the eosinophils also can play a role in COPD patient. And this is again a different phenotype. The eosinophilic COPD or this kind of phenotype has high eosinophil counts in the airways, and they are more exacerbators. And these are the patients who are required to be treated with inhaled corticosteroids. Now, coming to diagnosis, so these are the features of asthma and COPD. Coming to features of asthma, the onset is before 20 years of age, but you can also have a late onset asthma. Whereas in COPD, most of the time, the onset would be after 40 years of age with a prolonged history of smoking. There is a variation in the symptoms over minutes, hours, or days. So there is a variability of the symptoms in asthma, whereas in COPD, the symptoms would be persistent despite the treatment. So you may treat them, but their symptoms would always be there. In COPD, in asthma, the symptoms worse during the night or early morning. So somebody who is coming to you with a history of nocturnal cough, right, or nocturnal wheeze, he is possibly suffering from asthma, and this patient has to investigate it that way. Whereas in COPD, there could be good days and bad days, but always daily symptoms, and the patient would have the history of exertional dyspnea. So, doctor, when I walk, I feel dyspneic or I feel breathless. Now, in asthma, there are triggers which lead to COPD, the asthma exacerbation. The triggers could be exercise, emotions, dust, allergen, and exposure. And if these triggers are not taken care of, they would have persistence of the asthma symptoms, and the asthma would remain uncontrolled. So in asthma management, the control of the triggers is very, very important. Wherein COPD patients, the patient would be having chronic cough and sputum, which precedes dyspnea unrelated to the triggers. So you may not find any trigger except that the patients would be smokers, right? And majority of times they would present with cough, and which is something called as a smoker's cough, where somebody else would be noticing that this person is coughing a lot, but he himself would deny. He would say, "No, I don't have any problem," but others would notice it. And then this cough is followed by dyspnea, which is usually exertion. So it will start off when the patient tries to climb the stairs, and then as the disease progresses, then it can be addressed also. In asthma, you got a variable airflow limitation, whereas COPD, the airflow limitation is persistent. So you don't have variable, you never find a normal PFT in patients COPD, whereas in asthma, you may find intermittent normal PFT, as I said. Now, family history of asthma and other allergy conditions is there. They have got, urticaria, rhinitis, sinusitis, whereas COPD patients have heavy exposure to tobacco smoke or biomass fuel. In asthma, the symptoms do not worsen over time, and symptoms vary seasonably. And if they are treated well, they remain symptom free and do well. But COPD patients, if the patient continues to smoke, the symptom slowly worsen over time, even though the patient may be treated. This asthma patient shows good immediate response to bronchodilator therapy, whereas COPD patient got limited relief. They get a partial relief provided by the bronchodilator therapy. In asthma, if you do a chest X-ray or CT scan, you'll find the lungs are normal structurally. But in COPD patients, you may find restrictive lung disease, hyperinflation, the bulla, right, some bronchiectasis. So these could be the features of COPD patients. So what are the clinical indicators of COPD? COPD patient would have dyspnea, which is progressive over a time. Important thing is the progressive, it is not episodic. Progressive over a time. They become worse with exercise, and the dyspnea is persistent. These patients would have recurrent wheeze. They present with chronic cough, which may be intermittent, may be non-protective. They have a history of recurrent lower respiratory tract infections. As I said, they've got a predominance of B cells, and they have got colonized airways, which cause recurrent infections. And then they have got a history of risk factors, especially the tobacco smoke from home cooking, which is very prevalent in our villages, occupational dust, vapors, fumes, gases, and chemicals, and host factors like genetic. And those factors are also there, like alpha-1 antitrypsin deficiency. I don't want to go into that detail. So if you do the spirometry in these patients, this is the normal spirometry. But in COPD patients, you do a post-bronchodilator spirometry. You find that both FVC is reduced, the FE1 is reduced, but the important thing is the ratio between FE and FVC, that is FE1 percentage, is less than 70%. So here it is 0.56. So this is a typical spirometry finding of airflow obstruction in a patient COPD. Now there's something called bronchodilator reversibility. So when we do a spirometry in patient with obstructive airway disease, we do first a pre-bronchodilator spirometry. Then we give them inhalation of a bronchodilator, which is usually a combination of salbutamol and ipratropium, short-acting SABA, or combination of SABA and LAMA, SABA and SAMA. And then we then we repeat the procedure again, repeat the spirometry again, we look for the reversibility. So if there is an increase in FE1 from baseline pre-bronchodilator by more than 200, then we say it's reversible. And percentage-wise, if there is a increase of more than 12% from the baseline, that is the pre-bronchodilator therapy, after bronchodilator, we say it's a reversible condition. Now, for example, in this patient, here you've got the FE1 FVC ratio, which is 68%, which is less than 80% in patient of asthma. So you got obstructive airway disease. But if you look at the pre-bronchodilator FE1 is 2.76 and post-bronchodilator FE1 is 3.16. So there is an improvement of approximately 370 ml and 13.6% from the pre-bronchodilator level. So it means this patient has got a good reversibility, and this is consistent with the diagnosis of asthma. Whereas in COPD patients, there is no post-bronchodilator reversibility. Here, you've got a patient where you got the FE1 is the post-bronchodilator is something that you look at when you talk of diagnosis COPD is less than 56%. It means it is less than 7%. So this patient has got COPD. Now, how we prove it? Because if you see pre-bronchodilator, post-bronchodilator, there is hardly any change, right? And there is hardly any percentage change. So it means a fixed obstruction, which is suggestive of chronic obstructive pulmonary disease or COPD. So this is how you know the bronchodilator reversibility differentiates between COPD and asthma. And therefore, every patient of obstructive airway disease should undergo a spirometry. Now, coming to management, the goals of treatment of both asthma and COPD is to reduce the symptoms, to reduce number of exacerbations, and also to improve the quality of life. These are three primary goals of the treatment. Now, coming to management of asthma first. So, management of asthma, you treat them with therapy, which is classified as a controller therapy and reliever therapy. And this is quite interesting, as a matter of fact. So, controller medications are those which are there to reduce the airway inflammation. As I said, the airway inflammation, airway hyperresponsiveness is the key trigger in the pathophysiology of asthma. So your primary goal is to reduce the inflammation, is to control the inflammation. This is what the controller medications do. And if you are able to control the airway inflammation, then you will be able to control the symptoms. You will also reduce the risk of exacerbation, and you will also reduce the decline in the lung functions. So controller medications are also used as a prophylactic therapy to prevent further exacerbation and to keep the asthma under control. Okay. So controller medications also used for the prophylactic therapy. So ICS alone and in combination of inhaled corticosteroid and long-acting beta agonists are the first-line controller medications taken regularly once or twice a day as maintenance therapy or the controller therapy. So inhaled corticosteroid is the cornerstone because these are the inhaled corticosteroids, the ones who will, control the inflammation, and usually in combination with LABA, they are prescribed. So regular use of control medication is recommended for long term, even when the symptoms are under control as a maintenance therapy. So this is important. Asthma is a patient who is an asthmatic who requires a long-term regular treatment, even though his symptoms are under control, right? That is used as a maintenance therapy to prevent, worsening of his asthmatic symptoms and to prevent exacerbation. So regular use of controller medication, that inhaled corticosteroid with or without LABA, is the mainstay of the treatment of asthma. So as I said, anti-inflammatory agents like corticosteroid remain the first line and cornerstone treatment of asthma. The other controller options include the leukotriene receptor agonists like montelukast, long-acting muscarinic agents like tiotropium, the sublingual immunotherapy, azithromycin. So these are the other controller, but they are not the substitute to the basic therapy of controller medication, that is the combination of ICS-LABA. So they remain the cornerstone if the patient is not if asthma is not controlled with this combination of ICS-LABA, then you try to think of adding these other controller options. And then last but not least, the biologicals, which are beyond the scope of today's presentation. They are used for various phenotypes, as I just described while describing the pathophysiology. But these are the domains of the experts, where those go to step 5 asthma or very severe asthma, then you require these biological therapy to control asthma. Now coming to reliever medication. Reliever medications are the emergency medication. They are used as need basis for the relief of symptoms during worsening of asthma or exacerbation as reliever therapy. So they give a quick relief to the patient, right? Whereas the controller medication is to control the onset of control the to prevent the exacerbation and to to make the patient symptom free, as a matter of fact, as a preventive therapy. Whereas reliever medication are used in emergency to relieve the symptoms, and therefore they're also called as rescue therapy. So reliever medications, the quick relief medications, patient who is panting for breath needs, a medicine which gives him quick relief. They are used to relieve acute attacks of bronchoconstriction during an exacerbation of asthma, which we call as asthma attack. And reliever medications are usually the short-acting beta agonists, that is SABA. The anti-muscarinic, the short-acting SAMA, the short-acting muscarinic agents, the SAMA like ipratropium is also a reliever medication, and many times use a combination of SABA and SAMA, that is salbutamol and ipratropium, right? The combination which is available as a dual, right, for as a reliever medication. The xanthine preparations like theophylline are the bronchodilators, which are not recommended by the Western world, but they are included in our Indian guidelines. But as a matter of fact, theophylline are not preferred, in the management of asthma. Okay. Important thing is the formoterol. Formoterol is the only long-acting beta agonist, which is also used as a reliever medication. I'll come to this. This is a very important medication. This is a very important molecule, right, for the relief symptoms. So these are the short-acting beta-2 agonist receptors. Adrenoreceptors agonists like SABA, like you got the salbutamol, levosalbutamol, terbutaline, they got a quick onset of action of less than 5 minutes and short duration of action of 4 hours, right? So they are given as rescue therapy for relief of symptoms. Then you have the long-acting beta-2 agonists, which have a long duration of action, say more than 12 hours. Then you got the ultra-LABAs available, which have a duration of action more than 24 hours. So the example of LABAs include the formoterol, salmeterol, the most commonly. The newer ones are the indacaterol, olodacaterol, and then vilanterol, they are available. But formoterol, look at it. Its onset of action is less than 5 minutes and duration of action is almost 12 hours. So this is the only LABA, which is also used as a reliever therapy purely because its onset of action is very short, is less than 5 minutes. Now there is a concept which has emerged now as the anti-inflammatory reliever. So we know the reliever medication is a short-acting beta agonist like salbutamol. But if you add a rapidly acting ICS to it, then it is called as anti-inflammatory reliever, or AIR. So this is the newer concept. And now we are actually combining, even for reliever, we want to give anti-inflammatory drug because we want to control inflammation at every point of time. The symptoms are occurring because the inflammation has increased. So you want to reduce the inflammation also by giving a reliever therapy. So that's why the concept comes that you also combine a rapidly acting inhaled corticosteroid. Now I talked about formoterol. Formoterol is a wonderful molecule. It's the only LABA which is also used as a reliever therapy in combination of ICS. So this gives a very good advantage. So here you've got an ICS formoterol combination which can be used as a controller. And this ICS formoterol combination can also be used as reliever, right? So it gives an edge where the same molecule can be used both as a controller therapy and also as reliever therapy. So various anti-inflammatory liver therapies include formoterol plus low-dose inhaled corticosteroid like budesonide or beclomethasone. So you've got a combination of formoterol and budesonide, commonly available as Foracort. Then ICS salbutamol combination is there, where you got the beclomethasone, levosalbutamol combination available with us, which is the market is Aerocort. But the Foracort combination, there is a formoterol and low-dose ICS of budesonide is the key in the management of asthma. The non-formoterol LABAs in combination with ICS cannot be used as reliever. So formoterol is the only LABA which can be used as a reliever. And this has led to the concept of maintenance and reliever therapy, or MART therapy, or also called as single maintenance and reliever therapy, or SMART therapy, where treatment regimen includes ICS formoterol inhaler every day as a maintenance dose and also as needed for the relief of asthma symptom for reliever dose. So single inhaler works for maintenance, and in case the patient has the burst of symptoms of asthma during exacerbation, he can use the same inhaler for relief of symptoms also. So the patient is not confused, very comfortable. The child who goes to the school can carry only one inhaler in his bag, and if he finds any symptom in the while he's studying, he can just use that inhaler. He's not confused and not searching for this inhaler or that inhaler. So this makes the therapy very smart. So the MART, or the maintenance and reliever therapy, can be used only with combination of ICS formoterol inhaler such as budesonide formoterol combination, which we have is the formoterol, the Foracort combination. There are various other companies which are making this combination, and this is the most prevalent combination which is used. And as I said, combination of ICS with non-formoterol lavas or ICS lavas cannot be used as SMART therapy. So for SMART therapy, only this combination of budesonide formoterol is used. As I said, MART is also sometimes called SMART therapy because you're using single inhalers. It's called single inhaler maintenance and liver therapy. And the meaning, of course, is the same. So this brings us to the management of asthma, which is the stepwise approach. So you got the two tracks, as a matter of fact. So in track one, you're using ICS formoterol, that is budesonide and formoterol, as a controller, and also using ICS formoterol as reliever. So you're using only a single inhaler for the management of therapy, management of asthma, which is called a MART strategy. In track two, you can use any ICS, like you can use fluticasone, you can use memetazone, and any kind of lava, like you can use the solmetrol, valentrol. So in track two, you can use any combination of these two. But important thing here, the reliever is either SABA, that is levosalbutamol, or as needed ICS SABA combination like or have got Aerocord, where you got a beclomethasone and levosalbutamol combination. But if you look at the current management, the preferred therapy is the track one. The 80%, 90% I'm using the track one therapy. So I'll be focusing on this because that is very convenient. And overall, the studies have found the outcome with the SMART therapy is better as compared to the controller therapy because as such the compliance with this track one improves. We know asthma is a chronic respiratory disease and it requires a prolonged treatment. And therefore, the compliance and outcome is better with MART therapy. And that's what I'm going to discuss as a preference. So in track one, you're using ICS, that is budesonide formoterol as a combination. So if the patient's symptoms are less than 4 to 5 days a week, then it falls in step 1 and 2, and then you can only use this combination SOS basis. So if the symptom is less than 4 to 5 days a week, so when patient's symptom, we can just use this combination of budesonide formoterol. Step 3, the symptoms occur most days or the patient wakes up with asthma once a week or more. Okay. So then he's step 3, there you use a low dose combination of the ICS formoterol. Okay. Step 4, you use the medium dose of maintenance ICS and formoterol. Okay. And here in step 4, the patient would be having daily symptoms or would be waking with asthma once a week or more and would have a low lung function, as a matter of fact. And step 5 is the one where the patient has got a difficult to control asthma, where the patient is symptomatic and has got frequent exacerbation. And there you use high dose of maintenance inhaled corticosteroid and formoterol. You also add LAMA to this. And these patients have to be referred for phenotyping for the biological therapy for the experts. But important thing is while in every step, if the patient has got increase in symptoms, he can use the same ICS formoterol combination for relief of symptoms for quick relief. Now coming to the management of asthma, the key in this management of asthma is the smoking cessation because the only disease modifying approach. So if a COPD patient continues to smoke, his COPD would worsen over a period of time, whatever you do. The bronchodilator is the cornerstone of the treatment in COPD management, unlike asthma, where the IC is the cornerstone of the treatment. And bronchodilators improve the airflow and reduce hyperinflation. In contrast to asthma, the anti-inflammatory drugs like inhaled corticosteroids are restricted to patients who have got frequent exacerbation and those who got an elevated eosinophil level. So, COPD, number 1, stop smoking. Number 2, use bronchodilator as the mainline treatment. And number 3, in selected cases, you can add ICS to bronchodilator therapy, that is LABA-LAMA combination, right? If the patient with frequent exacerbation has got elevated eosinophil levels. So this is a gold ABA assessment tool where you confirm the diagnosis of patient COPD by doing a spirometry where the FEV1 FVC ratio would be less than 0.7. Then you assess for the airflow limitation. Based on that, you divide into various grades, gold 1, gold 2, and gold 3. So somebody who's got FEV1 FVC ratio, FEV1 of less than 30% would be gold 4. Now, important thing is the severity of FEV1 reduction does not determine the type of therapy, right? But it gives you an idea. Somebody who's gold 3 or gold 4 is at higher risk of exacerbation, higher risk of mortality. So they have to be very careful with these patients. But if somebody's got FEV1 less than 30 and has got a gold FEV1 where the FEV1 is more than 80, then it does not really change any treatment. The treatment actually depends upon the symptoms and risks of exacerbation. So that is very important. So basically, your treatment modality depends upon how many exacerbation the patient has got in the last year and how symptomatic he is. And therefore, it's divided into 3 groups. Group A is the one who are less symptomatic, have got less exacerbation a year. Group B is a group where the patient is continues to be symptomatic, is highly symptomatic, but is not exacerbating. And group 3 is a patient who are more exacerbating, like they got equal to or more moderate exacerbation in last year, or less more one or more exacerbation leading to hospitalization. And those were symptomatic, right? So this falls into group E. So this is a newer classification of the COPD in GOLD guideline management. So this box actually determines the type of treatment that will be required for these patients. So just to explain it further, so in group A, the patients who are not symptomatic, those who are not exacerbating too much, then you can just use a single bronchodilator. The choice remains LAMA, long-acting muscarinic agent like tiotropium. Group B, those patients who are highly symptomatic but are not exacerbating, you give a dual bronchodilator therapy, which is a combination of LAMA and LAMA. So you can give a formoterol and you can give a tiotropium combination, right? And these patients are likely to do well. In group B patients, again, the LAMA remain the cornerstone of the treatment. But if the patient has got a high eosinophil counts, right, then you can add ICS to inhaled corticosteroids to LAMA combination. Now, ICS and LAMA combination is not recommended in GOLD, not recommended in COPD patient, whereas ICS LAMA combination is the cornerstone in the treatment of asthma, but here it's not recommended. So if you are using LABA with ICS, LAMA has to be there, right? So you add ICS only when the patient got more than 2 moderate exacerbation or 1 exacerbation requiring hospitalization and his eosinophil counts are more than 3, only then, inhaled corticosteroids are added. And this is what is called as a triple combination therapy. Coming further to follow-up pharmacological treatment, so somebody who's got a high level of dyspnea or is very much symptomatic, so you can start with LABA or LAMA. If the patient does not improve, then you can give a combination of LABA or LAMA, right? If the patient is not doing well, then you can switch to other inhaler devices, maybe from MDI to DPI, or maybe you can change the combination of LABA or LAMA in your patient. Now, those who got frequent exacerbation, you can start with LABA or LAMA, right? And if the patient is exacerbating, if his eosinophil count is less than 300, then you give a combination of LABA. But if patient has got eosinophil count of more than 300, you would start with LABA ICS combination. Okay. And once the patient exacerbation improves and his symptoms come under control, then you can de-escalate the inhaled corticosteroid and continue with LABA combination. But somebody who is a LABA combination has got exacerbation, right? And if his eosinophil counts are more than 100, then you can get inhaled corticosteroids. So inhaled corticosteroid can also be added in a patient who has been on LAMA has experienced frequent exacerbation, his blood eosinophil count is more than 100. But if his blood eosinophil count is less than 100, then you can either give roflumilast if the patient is higher of chronic bronchitis component, and azithromycin as a maintenance therapy in a small dose on daily basis in those who are former smokers. So where is the role of inhaled corticosteroids, right, in COPD patients? So if there is a history of hospitalization for exacerbation COPD, more than 2 moderate exacerbation COPD last year, has got a blood eosinophil count more than 300, and has got concomitant asthma. So there is a combination of asthma which is there, then you would use the inhaled corticosteroid in a COPD patient, otherwise you won't use it. You can still favor use of the inhaled corticosteroid if there is 1 moderate exacerbation of COPD per year and his blood eosinophil count remains 100 to less than 300 cells, right? And he has been on regular LAMA combination, then you can consider use of the ICS in those patients also. But inhaled corticosteroids would be contraindicated if the patient got history of recurrent pneumonia, has blood eosinophil count less than 100, and history of tuberculosis. So if somebody who has got a TB with COPD, you would avoid using inhaled corticosteroids. So to summarize, asthma is a chronic inflammatory disorder of the airways characterized by recurrent episodes of wheezing, breathlessness, chest tightness, and coughing. Asthma is associated with variable airflow obstruction that is often reversible, either spontaneously or with the treatment. COPD is a disease characterized by persistent respiratory symptoms, for example, dyspnea, cough, and sputum production. Unlike asthma, which is often diagnosed early in life, COPD is a progressive condition of declining lung function that typically appears and is diagnosed after 40 years of age. The goal of treatment is to reduce symptoms, number of exacerbation, improve the quality of life. ICS alone and in combination of ICS LABA are the first line controller medications taken regularly once or twice a day as maintenance therapy, even when the patient doesn't have any symptoms. Track 1 or smart therapy is the preferred therapy in asthma where you use a combination of budesonide formoterol as maintenance and as a reliever therapy. Bronchodilator is the cornerstone in the management of COPD patient, unlike the asthma where the ICS remains the cornerstone of the treatment. Triple therapy with inhaled corticosteroids, LAMA and LABA is used in COPD patients who are frequent exacerbators and have high eosinophil counts. Control of triggers in asthma and smoking cessation COPD are important interventions in the outcome of diseases. So anytime you talk of asthma, first find out the triggers and treat them, right? Take care of them. And COPD patient, put them in a smoking cessation program. That's very, very important. It's not cessation, it's cessation. Thank you. So with this, I would end my talk and would be very happy to take any questions. Thank you.
Thank you, Dr. Goel, for a nice talk. There are some very, very important questions. First question is there any role of oral therapy like oral theophylline or oral steroids in management of COPD and asthma? Because in GINA or GOLD guidelines, they don't appear anywhere. But in Indian practice scenario, we use it left, right, and center during our practice. So currently, how do you recommend the use of this oral therapy like theophylline and steroids, oral steroids in acute exacerbation of asthma and management of COPD?
So you're right, sir. Absolutely. The GOLD guidelines and the GINA guidelines do not recommend the use of theophylline because they believe that, the window of uh, toxicity is very small, right? The therapeutic window is very small. And if we cross that therapeutic window, the chance of toxicity is very high. But if we in my practice and practice of various physicians like yours also, we hardly find any side effects of theophylline. We do find the tremors, the tachycardia with inhaled bronchodilators like the these salbutamol and levosalbutamol, but you don't find this happening with theophylline. So the Indian guidelines do recommend use of theophylline in patients whose symptoms are not controlled on high doses of LABA and LABA, right? So in those cases, you can give it, which may be asthma patient, which can be a COPD patient. But your first line treatment would be LABA-LAMA combination, okay? In patients of asthma, you would add inhaled corticosteroid, of course. But in COPD patients, LABA-LAMA patient is there. Now, the patient who is on LABA and LAMA combination is still symptomatic, then you can add theophylline on regular basis.
And what about, sir, oral or injectable steroids in acute exacerbation of asthma as well as the management of COPD exacerbations?
Correct. So you're absolutely right, sir. The as far as the oral corticosteroid, injectable corticosteroids are concerned, they are recommended during exacerbation of both asthma and COPD. So they have to be given. But they have to be given for a very short period of time, say 5 to 7 days, and then we have to stop them, even though the patient's symptoms may be under control or not, especially if the patient got a COPD patient. Now, as far as the oral corticosteroid in COPD patient as maintenance therapy is not recommended. It's absolutely not recommended. But in difficult to treat asthma patients, right, low dose oral corticosteroid can be given as a maintenance therapy, but nowadays we have got the biologicals available. So if we get such patient who requires a maintenance oral corticosteroid therapy to control his symptoms, then we rather go for a biological therapy in these patients rather than continuing with the oral corticosteroid because OCS have got a lot of side effects. That is something that you don't want.
Sir, there was a question about various devices like MDI or you can say that DPI devices or various types of nebulizers. So how do you rate them about their efficacy as well as the drug bioavailability in the lungs, drug deposition in the lungs by various devices?
Right. So, sir, actually, if you look at the gold standard remains the MDI with the spacer. So if you want to use MDI, then you should always recommend use the spacer, even though you may be very confident the patient would take the inhalation correctly. So spacer is very important. But now we have got the devices, which got ultra thin, ultra fine particles, the extra fine particles, which can have a deep deposition, right? So even in DPI, you got those devices. In MDI, you got the those devices where the deposition has been increased to now 35 to 40%. Usually the deposition is to approximately 20% with both DPI and MDI. So coming to the preference of using it, my preference would always be MDI with spacer. But again, it has to be individualized. We have to see what your patient wants. You have to give them the option. If somebody, who would not be able to coordinate with MDI and who's not willing to use a spacer, I would go offer him a DPI, right? Elderly patients generally prefer using DPIs more as compared to the MDIs. Similarly, there are few patients who think that nebulizers would be beneficial to them. They are more comfortable in nebulizers, so we give the nebulizer. But I want to make it clarify that the nebulizers do not have higher, deposition as compared to MDI with spacer, right? But yes, in certain individuals who cannot, handle the MDI and DPI, then nebulizers can be given as a long-term therapy. But yes, during acute exacerbation, nebulizers would be preferred over the MDI and DPI, as a matter of fact.
Sir, in the view of compliance, these days there are breath actuated devices, MDI devices. So, how do you rate them as a replacement for MDI with spacer? Because MDI plus spacer, they are difficult to carry, and probably they will have a poor compliance as far as this breath actuated devices are concerned.
They are very good, sir. In fact, if somebody can put, the only thing is they are a little more expensive and they're a little more bulky. But they are very good. Sometimes, some cases these device does not work. Then it is a waste. After some actuation, it doesn't work. So I think the technology still has to improve on that. The Cipla is the only company which is making these called as synchro breathe inhalers.
Yeah.
But yes, they are very good options. Again, they are more expensive, a little more bulky. But yes, they are a very good option. If
Sir,
you
probably
use
they are,
the sticker.
probably because of vital capacity of the patient's lungs is very low. In those patients, probably they won't be active. Otherwise, in patients where vital capacity is somewhat stable, probably they are effective there also.
Yeah, so actually you need at least 30 liter of
Yeah.
per minute of flow, to inspiratory flow to trigger them. So somebody who is not able to generate that kind of trigger flow, then these breath actuating devices would not be activated. So in very severe cases, they may not be very effective. But in majority of patients who can generate a flow of 30 liters per minute, this device would be activated.
And there is another question about HP axis suppression by chronic uses of ICS. Is it a possibility, or is it just a hypothetical question?
It's hypothetical. I mean, I have not come across study where, they have shown that the HP axis depression occurs because of inhaled corticosteroid. It doesn't happen really, sir. Especially in patients of asthma who have been using these inhaled corticosteroids for ages, for many, many years. This has not been observed. And this would occur only when the patient's got oral corticosteroids, prolonged use.
So
So
there was a
this is in
study.
particular in the children because we are more worried about the growth also simultaneously as not only the asthma but for the growth also.
So inhaled corticosteroids in children are very well recommended. They have shown that it doesn't cause any growth retardation, any metabolic syndrome. It has been very well documented. In fact, it has been shown that if children who are not treated with inhaled corticosteroids would later on develop more severe exacerbation, are at a higher risk of developing chronic obstructive pulmonary disease, the asthma converting into COPD. So those chances are there. So again, the cornerstone of treatment of asthma, even in children, remains the inhaled corticosteroids.
Sir, there was a study in Lancet in I think early 2000 that these long-acting beta agonists, they cause severe cardiac arrhythmias and sudden deaths. So I think the recent studies have refuted it. But what is the current status according to you?
Right. So problem that's a very good question. And in fact, the labas are not available as a matter of fact, as a single inhaler or single product, right? Primarily because they were misused and the asthmatic patients were treated without inhaled corticosteroid with lava alone. So that was the problem, and it's in fact led to higher mortality. So use of LABA without using ICS in patient with asthma causes more higher mortality. And that's why now LABA are not available as a single molecule. They're always available in combination with inhaled corticosteroids. And there is, in fact, the risk of arrhythmias is more with LAMA, as a matter of fact. The tiotropium causes more risk of arrhythmias as compared to LABA. Uh, but that's very little, very lesser. The arrhythmias occur, the tachycardia occur, the atrial fibrillation occur more with the SABA, right? Salbutamol and levosalbutamol. LABA, it is not that common. Majority time these patients would complain of tremors, as a matter of fact. They would say, कि, sir, doctor, मेरा हाथ कांप रहा है. So then you reduce the dose of LABA. But cardiac side effects are minuscules.
Thank you, sir. If anybody has any other question, because I have asked all the questions in the chat bot. So if anybody else have any questions, then he or she can unmute himself or herself and ask the questions directly to Dr. Manoj Goel.
Hello. My question is not to Dr. Manoj Goel,
Yes,
but
sir.
to you. One name is visible, MM. Is he more Mukut Gupta in Rewari?
Yes, yes, he is there.
I met him about 35, 40 years ago, so cannot recognize him. But looks like. Hi, Dr. More Mukut. If you can hear me.
Yeah, I am hearing you, but I don't remember ever meeting you.
I am Narendra Taneja, eye surgeon.
I have one question to ask from Dr. Manoj Goel.
Yes, sir.
Sir, when we give nebulization therapy for acute exacerbation of bronchial asthma, sometimes the condition worsens. What is the reason and what should be done immediately to restore the patient?
So it is not the nebulizer which is likely to cause the worsening of the condition of the patient as a metric. Sometimes, if you're using the tiotropium, sometimes it can cause reflex bronchoconstriction, but that's very, very rare. Very, very rare. So if the patient is not is worsening despite to nebulizer, it means he's going for a resistant or severe kind of attack of asthma. And this patient should ideally come to the hospital, get hospitalized, be treated appropriately, maybe with antibiotics, maybe IV corticosteroids, more frequent use of the nebulizers, right? So I think this would be a good sign.
Sir, I have got a patient who was nebulized with bronchodilators and corticosteroid. Patient complained that he has got exacerbation, he is not able to breathe.
Yes. So in that situation, you can give an oral corticosteroid to this patient or IV hydrocortisone to this patient, see, and try not to give him nebulizer if that is the sole thing that you think is the cause. And this patient can then be managed on DPI and MDI only.
Okay, sir. Thank you, sir.
Sir, any role of antibiotics in acute exacerbation of COPD? Because in many of the cases, the cause of acute exacerbation is infection. So I don't think GOLD guidelines have mentioned antibiotics anywhere as a recommendation.
No, sir. Antibiotics have to be given if there is an acute exacerbation of COPD. I mean, one of the important causes of exacerbation COPD is infection. So you have to cover them, especially for atypical organisms. So minimum at least clarithromycin or a combination of clarithromycin or beta lactam has to be given to these patients during exacerbation.
Any other questions?
Sir, why terbutaline produces tremors even in a small dose of 2.5 milligram DD? And secondly, is terbutaline injection available these days?
I'm not sure about it, sir, whether those injections available, because we do not give any oral terbutaline or oral salbutamol, as a matter of fact. That's no more recommended. And they would cause invariably, tremors. Mechanism, I don't know, but there is a very high risk of or high chances of developing tremors due to terbutaline. So we do not recommend any oral bronchodilator, as a matter of fact, apart from theophylline. No salbutamol, no ethylene tablet, no terbutaline tablet. We don't do it. And injection is totally out of practice nowadays. We don't do. The only oral bronchodilator that we give is the theophylline. That too in a low dose. It's not a high dose. So we give a, derifine, theophylline 300 milligram, maximum 400 milligram. We don't give higher 600 milligram or 800 milligram. That's not given.
Thank you.
Role of vaccine in COPD.
Excellent question, sir. Absolutely. All patients have to be vaccinated. So vaccination with flu, vaccination with pneumococcus. Then now others available nowadays like Boostrix is there and shingles. So they must be covered for all these vaccines. Very important.
So if there is no other questions, I would request our secretary, Dr. Soni sir, for thanks. Dr. Soni sir.
Yes, sir. Thank you very much for a nice presentation. जरूरी था सर, जिस हिसाब से पोल्यूशन बढ़ रहा है, अस्थमा बढ़ रहा है, चीजें बढ़ रही हैं, was much required. Thank you very much, sir.
Thank you, sir. Thank you so much. It's a pleasure being with you. Thank you so much, sir. Thank you. Looking forward to meeting again.
Thank you, Dr.
Sir, one question, sir.
Yeah,
Yes.
yeah.
Do you recommend boosters every 10 years, Doctor sir?
Yes, sir. Definitely.
Every 10 years after, it can be given after the age of 7 years and recommended from 10 years onwards till the age of 65 years.
Yes,
And
sir.
flu vaccine every years.
Yes.
And PCV 13 first, followed by PCV 20, PPSV 23.
So as far as pneumococcal vaccination, I think we are soon going to have PCV 15 or PCV 20 introduced to the country. So it's already introduced in the Western world, and the PCV 13 and PCP 23. They are out of practice, as a matter of fact. They are no more being recommended by the CDC at the moment. But in our country, the PCV 15 and 20 are not available. So still we have to persist with this PCV 13 and Pneumovax 23.
PPSV 23.
The point is the routine vaccination is given even in asymptomatic patient without any comorbidity after 65 years of age. So the choice is Pneumovax 23 at this point of time. PCV 13 is considered. It's a shared decision by the physician and the doctor and the patient. Otherwise, Pneumovax 23 is recommended. Like in COPD patients, smokers less than 65 years age, we give one shot of Pneumovax, right? At any age, maybe it is 48, 45 or 50. But we repeat the next Pneumovax after the age of 65. We do not repeat it every 5 years. That is not recommended. Okay. So after 65, every individual is entitled for Pneumovax at this point in time. PCV 13 by shared decision. And if you're giving PCV 13, then you give PCV 13 first, and then after 1 year, you give Pneumovax 23. But PCV 13 is not mandatory. Pneumovax 23 is mandatory. That is important. And before the age of 65, only Pneumovax is indicated in COPD patients, not PCV 13.
And
patient is above 50.
influenza vaccine every year.
So if the patient is above the 50 year of age, you must give PCV 13 first and then give PPSV 23.
Yes, that's right. So this is according to our IMA guidelines, the Indian Medical Association. You're right about that. But if you look at the international guidelines, it's not there. So yes, our Indian Medical Association guidelines does recommend after the age of 50 years. You're right, sir.
And once it will take time. It may take 2-3 years before these PCV 21 and 20 they become available in India. 21 were introduced only last year in June 24th. It will take time before they come in Indian markets.
The problem is that they have to go through some trials in India. That's the main reason they are not available. Because DCA does not approve any drug until it has gone a trial in India. So they are undergoing a trial. So we are likely to have them now available very soon. Yeah.
Thank you, sir. Nice to listen to you. And Pawan, hopefully we will see it on YouTube. All these talks, web series.
Probably I'll try. If I can upload them, then definitely I'll do that.
Thank you, sir.
You can take help from Indra Mohan if needed.
Yeah.
He can help you.
Yeah, we'll definitely.
Because not very. Even Dr. Kavita, she had started a channel of IMA.
We will start an academic channel for IMA Haryana, and we'll upload them at that channel instead of uploading them at cultural channel.
She can guide you. She started cultural channel. She will be able to tell you how to start your own channel.
We'll try that, and we'll probably try to relay them on YouTube live.
Right, sir.
Thank you, sir. Thank you. Definitely, we will try to make a YouTube channel for our academic program
Thank
also.
you, Dr. Jain. Thank you, sir. Nice to
Thank
hear you. I joined little late today. Forgot initially.
Thank you, sir. Thank you, everybody, especially Dr. Manoj Goel and all the participants. Thank you very much.
Thank
And
you.
good night.
Good night, sir. Good night.
Good
Thank
night.
you.
Good night.
Thank you.
Good night. Good night, Dr. Manoj. Good night.
Thank
Good
you, sir.
night, Jai Hind.
Thank you, sir.
Jai Hind ji. Jai Hind.
Thank you, sir.